Can you just confirm for me that you're hearing me well?
Yes, sir, hearing you well.
Okay, great. Okay, so for this lecture, we're going to go through the definition of weakness, how we assess weakness, how we localize the lesion, review various pathologies that can present with weakness, and the various patterns of presentation, and then we'll look at the diagnosis. So weakness is really defined as a poor ability to move a particular part or parts of the body. There are two terms that we use in medicine. One is paresis, which means partial loss of power, and the other is plegia, which means total loss of power. But you will see sometimes that loosely we use these interchangeably. In terms of the quantification of power, the MRC scale for muscle strength is still used, and power is graded according to grades 0 to 5. Just to remind us that grade 0 means that there's no movement at all. Grade 1 means that there's a flicker of movement only. And for grade 2, there's active movement with gravity cancelled, so usually in the horizontal plane. For grade 3, there's active movement against gravity, but not against resistance. Grade 4 means that there's active movement against gravity and resistance. And grade 5 means that there's maximum movement against resistance, full power. Just want to point out to you that the term active is important. So reflex movements are not used in the grading. Want to introduce to you a term, the gross or a scale, the gross motor function classification system, which is used to describe the function, motor function of children with cerebral palsy. There are 5 levels. Level 1, meaning walking without limitation and ambulatory in all settings. Level 2, the child is able to walk with limitations. So walks without aid, but this is limited in community settings. Level 3, the child always needs to walk with an aid, and this is usually a handheld mobility device. Level 4, the child requires a wheelchair, but may be able to self-propel in the wheelchair. And level 5, the child is fully dependent for mobility. So you can see from these illustrators, just paying attention to those on the left. GMFCS level 1, the child is able to walk, to run, to walk upstairs without support. For level 2, the child is able to walk in their usual settings, but may need assistance like using a rail to walk upstairs. Level 3, the child always needs a handheld mobility device, and in particular settings, rough terrains, over long distances, they may need to use more assistance in terms of a wheelchair. In level 4, the child always uses a wheelchair, but is able to self-propel. And level 5, the child is fully dependent for mobility. So I'm gonna see, okay. 1 second, please. I want you to tell me if you're seeing this video.
Yeah, we're able to see the video.
No,
We can see, but
no,
we can see, but not hear.
but not here. Give me a second, please. And you saw the video clearly?
Yeah.
Were you able? Okay, hang on a second. Okay, I'm going to try that again. I hope it will work. Able to hear?
No.
No. Okay. I'm going to share that video with you at the end, so just that we don't use too much time. But and you can go through in your own time. But it really goes through the gross motor function classification system. Not sure why. Can't figure out now why I'm not hearing you're not hearing the audio. All right, so I'll share this at the end and ask you to review it in your own time. But it really is a 4-minute video that nicely explains the gross motor function classification system. All right, so we also need to remember various milestones in motor development, and these include the attaining head control at 3 months, being able to reach purposely for objects at 4 months, being able to sit without support at 6 months. Can somebody give me another fine motor milestone that's achieved at 6 months? Tell me, what is a child able to do at 6 months? Akil?
Hello, morning. That you said 6 months.
Yes. What fine motor ability does a child have at 6 months?
Um, can they do the rake? Well, no, that's not fine motor.
So they're able to reach purposefully at 3 to 4 months. What do they do at 6 months?
Can they pass from one hand to the other?
Absolutely. So they transfer objects at 6 months. What do they do, Anya, in terms of gross motor milestones at 9 months before walking at 12 months? Anya? Okay, Mr. Omotola?
It's Miss.
Or Miss, sorry.
It's okay. They can pull to stand and they can cruise.
Absolutely. Very good. Pull to stand at 9 months and walk without support at 12 months. But walking is not considered delayed unless it's not achieved by 15 months. So there's a range. So there's also the crude finger thumb grasp at 9 to 10 months. And there's the mature pincer grasp at 12 months. At 2 years, they climb their stairs one step at a time. So one foot on one step, and they bring the other foot up to meet it. The next right foot on one step, they bring the left up to meet it. Whereas they climb stairs alternating feet at age 3 years, and by 4, they're able to hop on one foot. So, Mr. Jones, what other motor milestone does a child have at 3 years? It has something to do with threes.
With what? Three?
Threes. Threes. That's a clue. Something that children do for fun.
Oh, the building block.
No, 3. Motor. Gross motor.
Motor. Hop on one foot for 3 steps.
So that's a 4-year milestone, hopping on one foot. Pedaling a tricycle.
Oh yeah. Okay.
All right, I don't think you're all paying attention, so we're going to go through this again. Head control at 3 months, reaching purposefully at 4 months. Mr. Bisram, what other fine motor milestone at 6 months? Your colleague gave that answer before. Jamaica, what fine motor milestone at 6 months?
Morning, Doc. They can transfer objects from one hand to the other.
Mr. Bisram, what gross motor milestone at 9 months? One of your colleagues gave this answer already. Okay, Racine, what gross motor milestone at 9 months?
You said gross motor, correct?
Yeah.
Yeah, so they would be pulling to stand and cruising.
Fantastic. Walking at 12 months. Crude pincer grasp at 9 to 10 months. Sawan, what fine motor milestone at 12 months?
They can make a mature pincer grip.
Very good. Running or climbing stairs one at a time at 2 years. Tanya, what gross motor milestone apart from climbing stairs alternating feet at 3 years? Zaria or Tanya? Anyone, go ahead.
Riding at the tricycle at 3 years.
Fantastic, great. All right, so the next step is to localize the lesion. So when we have a child who has abnormal motor findings, we want to ask ourselves, where is the lesion? Okay, so the motor exam could either be normal, or you may have findings in keeping with an upper motor neuron lesion or a lower motor neuron lesion. So the upper motor neuron are cortical motor neurons that project to the anterior horn cells in the brain stem and spinal cord. So these motor neurons originate in the motor cortex, primary motor cortex. Then their neurons descend through the white matter, the subcortical white matter, through the internal capsule, descends through the brain stem, so midbrain, pons, medulla. Here they give projections to the cranial nerve nuclei, motor nuclei. Then they cross at the medullary pyramids and then descend in the anterior and lateral cortical spinal fasciculi of the spinal cord to synapse at the anterior horn cell. So anywhere from the motor cortex down to spinal cord just before synapsing with the anterior horn cell is the upper motor neuron. So Zaria, question for you. When we speak about the motor cortex, where in the cerebral hemispheres is that?
Morning, Doc.
Morning, Zaria.
The motor cortex.
Don't remember.
No.
Okay, anybody remembers? All right, so I just wanted to remember that in the cerebral hemispheres, we have the central sulcus, which separates the frontal lobe from the parietal lobe. Anterior to the central sulcus is the precentral gyrus. Do you remember that? And that is the motor cortex. Do you all remember that? Yes, no?
It sounds familiar, Doctor. I think we need to revise it.
Right. And so the precentral gyrus, which is the motor cortex, the primary motor cortex, is in the frontal lobe. Posterior to the central sulcus is the post-central gyrus, and that is the primary sensory cortex. And so that primary sensory cortex is in the parietal lobe. So we're talking about motor neurons that originate from the frontal lobe, motor cortex, precentral gyrus, and descend their cortical spinal fibers through the white matter, internal capsule, brainstem. Remember, we start with midbrain, then pons, then medulla, decussate or cross at the medullary pyramids, and then descend in the anterior and lateral corticospinal fasciculi. Clear to everyone? This is just to remind us that this is the arrangement of the homunculus, and that on the lateral aspects of the cerebral hemisphere, you have a large representation for the head, neck, and upper limb, and the lower limbs are subserved on the superior medial aspects of the cerebral hemisphere. The lower motor neuron, on the other hand, starts in the spinal cord and begins at the anterior horn cell, leaves via the ventral nerve root, meets the sensory nerve in the peripheral nerve. Then you get to the neuromuscular junction and muscle. So anywhere from anterior horn cell to muscle is lower motor neuron. You can slow me down, ask me questions if you need to. So features of an upper motor neuron lesion include some wasting or hypertrophy in a long-standing lesion. So acutely, you would not have wasting. The tone is increased, so there's spasticity, there's hyperreflexia, and an extensor plantar response. Whereas with a lower motor neuron lesion, wasting is characteristic, so there's markedly reduced muscle bulk, the tone is reduced, there's hypotonia, reflexes are depressed, hyporeflexia, and the plantar response is variable. The pattern of wasting can help us to determine where in the lower motor neuron is affected. So other features that help with localization, the presence of fasciculations tells us that the lesion is at the anterior horn cell. With peripheral nerve disease, you get more distal findings, so distal wasting associated with sensory loss and autonomic dysfunction. For neuromuscular junction lesions, they characteristically present with excessive fatigue, so fatigue as effort increases. And for muscle localization, this tends to affect mainly the proximal group, so you get proximal wasting and weakness, and the reflexes are preserved. So this is not going to work. I'm going to pause 1 second and try something again because I think this is important. I'm seeing so much here. I'll probably try this. Are you seeing my PowerPoint here, or?
Are you seeing the PowerPoint?
You're seeing the PowerPoint? What slide are you seeing?
The slide with the link for the demo.
Oh, great. All right, so this should work. Are you seeing a video?
Yes, I see a child sticking out their tongue.
Right. So those are fasciculations of the tongue. Let's just play that again. Sorry. Okay, so it's like a bag of worms with a lot of rippling beneath the surface of the tongue. And just to show you another video of fasciculations, because I find we don't quite. Can you see that?
Yes, ma'am.
Are you seeing the, okay, so you can see that it's not a discrete movement of the muscle, but it's a movement, it's a ripple in the muscle fibers within the body of the muscle. Okay. All right. So our next question is, what is a lesion? Okay, and we'll look at various pathologies. So just to say, those were videos of fasciculations. And fasciculations are maybe spontaneous. You see them without trying to induce them, or in the limbs, you may need to tap on the muscle to see if you can induce them. The movement is usually not a discrete movement of the limb, but you need to observe closely within the body of the muscle that you have tapped to see if you see any rippling. If you find fasciculations, then it tells you that the person has a problem at the level of the anterior horn cell within the spinal cord. Is that clear?
Yes, doc.
Okay. All right, so we're moving on to pathology. We may have congenital causes of problems that may present with weakness, and these include genetic problems such as muscular dystrophy or a hereditary neuropathy. The commonest one being hereditary sensory motor neuropathy or Charcot-Marie tooth disease. It may be due to some other intrauterine insult, such as an exposure to teratogens, such as an infection like your torch infections, maternal drugs, or due to a developmental malformation, which is usually due to a genetic problem or a teratogenic exposure. Acquired causes, you can use the mnemonic tin can bed me D. So, you could have trauma causing a peripheral nerve problem, like if you give a buttock injection, you could get a sciatic neuropathy, or a baby born a difficult vaginal delivery with shoulder dystocia may end up with an herb palsy due to brachial plexus injury. We can look at the effect of toxins, infections. We spoke about infections prenatally. Or we could speak about infections causing meningoencephalitis, or the immune response to an infection causing demyelination in the brain or the spinal cord. We know examples of nutritional deficiencies, such as B12 deficiency causing a dorsal column problem within the spinal cord. circulatory disturbances causing things like strokes and hemorrhages, autoimmune disorders causing inflammation like an encephalitis or a cerebritis, or may be associated with a vasculitis that could cause stroke. Neoplasia as a space-occupying lesion in the brain or spinal cord causing dysfunction. Blood disorders such as hemophilia, sickle cell disease, and so on, causing either hemorrhage or stroke. We can think about our endocrine disorders such as thyroid hypothyroidism causing a myopathy, and degenerative disease. And one of the degenerative diseases that's very catastrophic in pediatrics is spinal muscular atrophy, where these children have a deficiency in a survival motor neuron gene, and this causes anterior horn cell disease and causes progressive essential denervation of muscles, weakness, leading to respiratory failure and ultimately death. The influence of age, depending on the age of presentation, you may think of other particular pathologies. So if you have a child presenting with weakness in early infancy, you're likely to consider a prenatal insult, such as a genetic disorder, a developmental malformation, intrauterine insult, but also it may be due to some perinatal insults, such as hypoxic ischemic encephalopathy, infection, meningitis, encephalitis, and we should always remember inflicted trauma, so non-accidental injury. In childhood, injuries are common causes of neurologic dysfunction and weakness. Also, there's the role of infection, meningitis, encephalitis, malignant disease such as brain tumors, stroke, particularly in our population with children with sickle cell disease, and there is degenerative disease. So in infancy, the child tends to present in one of two ways. That presenting with delayed motor development from the beginning, so they're just not meeting their milestones, or presenting with loss of acquired motor skills. So you may have a child who presents, having probably had a significant perinatal history, and you notice that they have a poor suck, poor tone, unable to hold up the head. Then they're delayed in attaining the milestones of rolling over that may come in at 6 months, delayed with sitting up. They're not sitting up till 9 months, a year. And when they sit up, they're not able to sit up with their back straight, and so on. And you get that pattern of delayed motor development, which probably tells you that there was a static insult at some point, and this has just delayed their rate of motor development. But the other presentation may be that you have a child who started off with normal motor milestones. So they seem to be quick. They're holding up their head at 6 weeks. They're rolling over at 3 to 4 months. They're able to sit up at 6 months. And then they notice now that they're no longer sitting up with a straight back. Then they're no longer able to sit up probably by about 9 months. Then at a year, they're only able to roll over and so on. What do you think we should consider when we have that presentation of loss of acquired motor skills? Can anyone say?
Doc, when you say what should you consider, you mean
what diagnoses?
Well, infectious for starters, or
Okay, so an infection would probably cause a loss of motor skills initially, but they wouldn't continue to lose motor skills over time. So you'd have sort of an insult, they lose motor skills, and then they probably would just gradually pick up again. But I'm talking about a child who starts off fine, and then you notice over the course of about 4 to 6 months that they're losing milestones. What would you think about there? Any class of disease?
Dystrophy.
Okay, you're close. So it would be, you think about a degenerative disease, and the one disease that tends to present like, yeah, muscular dystrophy, localized to skeletal muscle, and also spinal muscular atrophy is something to think about. Okay, so in childhood, okay, so whoever said muscular dystrophy, probably not so much at this point, because muscular dystrophies tend to present older than infancy. So infancy, we're talking about 0 to 18 months, stretching it to 2 years, but the muscular dystrophies tend to present later. So they present in childhood often with an abnormal gait, clumsiness, frequent falls, and they lose their acquired motor skills. So a child with muscular dystrophy will often walk late. So instead of walking at a year, they may walk at 15, 18 months, and the parents may notice that when they started walking, they were walking on tiptoes. They seem to be walking strongly, but then they noticed that they would have frequent falls, and then things like climbing upstairs would become more difficult. And that is the typical presentation of a child with muscular dystrophy. In terms of, again, patterns of presentation in terms of chronology or timing, we have acute weakness, and I think one of the students alluded to this, that you could have some acute insult that causes weakness, and these would include something like acute flaccid paralysis, which may be due to Guillain-Barré syndrome, could be due to polio or some non-polio enterovirus, okay? And by acute flaccid paralysis, we mean that the child would have acquired weakness of the limbs with hypotonia and hyporeflexia. What is the particular pattern of presentation that you tend to get with Guillain-Barré syndrome? Does anybody know?
Good morning, Doc. Is it that the pattern of weakness it's from distal to proximal?
Absolutely, right? So it's an ascending pattern of weakness. Guillain-Barré syndrome is a condition in which it's believed, and it can be proven sometimes, that the child has suffered some viral or bacterial infection. Commonly viral, the bacteria that is associated is Campylobacter. And so the child suffers this infection, and as part of the inflammatory response, makes antibodies to this virus or this bacteria. But this antibody cross-reacts with the receptors to the myelin sheath, and therefore causes myelin injury and acquired demyelination. It tends to affect, therefore, the larger nerves before the smaller nerves, and that is why it has this ascending presentation. So the larger nerves would subserve the lower limbs, and then as the disease progresses, it affects progressively smaller nerves, and so you get this ascending pattern of weakness with Guillain-Barré syndrome. If you have an acute hemiparesis, you want to think about a cerebrovascular accident, so stroke or ischemia, or probably something like a cerebral abscess, or like a large tumor that has had an acute bleed into the tumor. If you get the presentation of an acute paraparesis, this is meaning that there's weakness in the lower limbs only, then that tells you that the lesion is at the level of the spinal cord. And with that, you have to think about spinal cord injury or inflammation or vascular malformation, and you must rule out a spinal cord compression, like from a diseased vertebra or a tumor or so on. With a monoparesis, we mentioned Erb's palsy in the neonatal period or sciatic nerve injury. And we also have cranial nerve paresis occurring acutely, such as involving the facial nerve with a Bell's palsy, and sometimes the abducens nerve with things like even with Guillain-Barré syndrome. Other patterns of weakness, more subacute or chronic, you're thinking about chronic infections like TB or HIV. Slower demyelination, you may think about a process like transverse myelitis. And in terms of chronic, those that are non-progressive, we think about cerebral palsy or a congenital myopathy. Or if it's progressive, we think about things like infection, neoplasia, some of the degenerative disorders such as Duchenne's, hereditary motor sensory neuropathy. We spoke about spinal muscular atrophy. And then there's a condition called familial periodic paralysis associated with hypokalemia, which can present with intermittent weakness. And then the pattern of relapsing, remitting weakness is typical of multiple sclerosis. So we're going to move on to speak now about cerebral palsy, which is a disorder of movement and posture, which is non-progressive, and it's due to an insult to the developing brain. So to the fetal or infant brain up until the age of 3 years. Cerebral palsy speaks about the disorder of movement and posture. It's non-progressive, but it may be associated with other accompaniments such as sensory disturbance, intellectual disability, communicative disorders, dysarthrias, perceptual dysfunction, and epilepsy. Okay, so with cerebral palsy, you may have multiple comorbidities, but cerebral palsy speaks to the motor problem only. In terms of types of cerebral palsy, the commonest type is the spastic type, and subtypes of that include hemiparesis, where there's weakness on one side, diplegia, where there's weakness of the lower limbs more so than the upper limbs, or tetraparesis, where you have 4 limbs pretty similarly involved. Then there's a dyskinetic cerebral palsy, or otherwise called choreoathetoid cerebral palsy, where the child presents with dyskinesias. And then there's a mixed type where you may have both spastic and dyskinetic. Less commonly, there's the ataxic cerebral palsy due to cerebellar dysfunction and the atonic cerebral palsy. So if you're able to see the slide, you could see that with spastic CP, you have problems at the level of the cerebral cortex. When you have dyskinetic CP, then the lesion is at the level of the basal ganglia. Where you have ataxic CP, the lesion is at the level of the cerebellum. And in the mixed types, you have multiple areas of the brain which are affected. So this is taken from the Nelsons again. So you could see that most commonly the cerebral palsy is spastic. So we're here seeing, you know, something like 85% of cases are spastic. And you can see that spastic hemiplegia means that you have weakness on one side, and that accounts for 25% of cases of cerebral palsy. and it's usually due to a vascular accident, so a stroke or intraventricular hemorrhage. Persons who were in clinic with me yesterday saw a child with spastic hemiplegia, and he had that classic circumductive gait with reduced flexion on the affected side. You have to swing the leg outward to clear the ground, and there's early handedness. So if you're taking a history and the parent tells you that they knew the child was right or left-handed, say by 6 months of age, that should make you think that there was some hemiparesis in that child, because usually handedness is not determined until 18 to 24 months of age. In spastic diplegia, as we said, the lower limbs are more involved, even though you may have some slight involvement in the limbs. And this is the type of cerebral palsy that is seen in survivors of prematurity, and is related to periventricular leukomalacia. And because both lower limbs are spastic, they tend to adduct, and they get this sort of scissoring gait, and before they start walking, they may have this commando crawl. Spastic quadriplegia means that all limbs are involved, and it's the most severe form of cerebral palsy, and is often associated with problems with swallowing, cognitive impairment, and seizures. And this usually means that there's diffuse involvement of the cerebral cortex bilaterally. The dyskinetic cerebral palsy, so-called extrapyramidal or chorea-affectoid, is due to basal ganglia involvement. And so these children would have involuntary movements or contractions affecting all muscle groups. So they have problems with posture, problems with movement of the limbs, but it also affects the speech and swallowing. So they have difficulty swallowing, and they have dysarthria. Because the lesion is at the level of the basal ganglia, intelligence is usually normal, and they have a low risk of seizures. Is everybody following so far, or do you have any questions?
Doc, could you please go over the part where you're mentioning the prematurity? I didn't get there properly.
Right. Okay, I'm going to come to it now. So with prematurity, these children tend to have spastic diplegia if they have any motor difficulty resulting. And by spastic diplegia, I mean that their lower limbs are more markedly involved than the upper limbs. And the gait usually results in a sort of scissoring gait. I'm just going to try and explain to you why that is so. So you can, let's see if I can find a pointer. Okay. Are you able to see my mouse move here?
Yes, Doc.
Okay, great. All right, so this is a cross section through the brain. Remember we spoke, these are the cerebral hemispheres. And in here, this little tip here is representing part of the lateral ventricle. Now, when the baby is born prematurely, say at 28 weeks, 30 weeks, or before 26 weeks, the brain is not fully developed. We appreciate that, right? And so brain development is still ongoing. Now, the most active part of the brain at that point, where a lot of neuronal proliferation is occurring, is in this periventricular area. Are we following that? So this periventricular area, because it's so metabolically active, will have a high demand for both nutrients, oxygen, and also blood supply. However, this part of the brain, the paraventricular area, is, as you can appreciate, is deep within the cerebral hemisphere. And so the blood vessels that supply this area are very thin and friable, and the blood flow in this area is sluggish. Are you following me so far?
Yes, Doc.
Okay, with my presentation screen, I'm not able to see you, which is why I keep checking in. Now, the premature baby, the baby is born prematurely, there is a mechanism that protects the brain from excessive pressures, and that's called cerebral autoregulation. So if you or I were to have a spike in our blood pressure, that blood pressure hopefully doesn't immediately translate to our cerebral circulation because there's cerebral autoregulation to sort of protect our brain from these spikes in blood pressure. Now, that mechanism is not well developed in the premature infant, so that any surge in their systemic blood pressure is easily transmitted to their cerebral circulation. And that's why we say for premature infants, there should be minimal handling and so on, because if you handle them excessively, there's a lot of noise, a lot of stimulation in their environment, then their blood pressures can surge. And this is easily transmitted to their cerebral circulation. All right, so if a premature infant, therefore, has that, where they get a surge in their blood pressure for some reason, then it's transmitted to their cerebral circulation. And remember, I said that these blood vessels that supply this area are very tiny and fragile and friable. So they're prone to rupture. And so these premature newborns are predisposed to periventricular hemorrhages. Is that clear? I also said that this area of the brain is highly metabolically active. It's with a high demand for nutrients and for blood supply and oxygen. So if you have a child who, on the other hand, goes hypotensive or hypoxic, then this area of the brain is also predisposed to injury. So premature infants are prone to injuries in the periventricular area, and they end up with these periventricular hemorrhages, leukomalacia, and that sort of injury to the brain. Now, if we look at the fibers that are descending from the motor cortex, what we know is that these nerve fibers are arranged with the legs most medially, then trunk, then upper limbs, then head and neck most laterally. So when you have a lesion in the periventricular region in a premature infant, it therefore tends to affect the descending motor fibers that are closest by, and those are to the lower limbs. And this is why premature newborns tend to be predisposed to spastic diplegia. Please let me know if that was clear.
Yes, it
Can
was,
you
Doc.
repeat that
Thank
one
you.
more time, please?
Okay. All right. So your colleague asked about spastic diplegia. And remember, we said that that's a pattern of cerebral palsy where there is predominant involvement of the lower limbs, so spasticity in the lower limbs. And we also said that this is a pattern of cerebral palsy that is likely to be seen in survivors of extreme prematurity. So I'm trying to say that in a baby who's born prematurely, brain development is not yet complete. And what is happening is that you're having a lot of cell division and neuronal proliferation, particularly in this region of the brain, which is the periventricular region. This region of the brain, which is highly metabolically active in the premature infant, has a high demand for oxygen, other nutrients, and blood supply. The blood vessels that supply this area, though, are coming from the surface. So by the time they get here, they're thin, they're friable, and the blood flow in this region at best is sluggish. So when you have any other insult, we said that cerebral autoregulation is not well developed in the premature infant, so their blood pressure spikes, is transmitted to the cerebral circulation, then they're prone to vascular rupture and bleeds in this area. Also, if for any reason they become hypoxic or hypotensive, this area is also predisposed to injury. So they end up having a pattern of injury to the brain resulting in periventricular disease or periventricular leukomalacia, because it's really white matter that is in this periventricular region. Now you can see the fibers, the corticospinal fibers, which are descending close to this periventricular region, and they're arranged so that the legs are most medially, head and neck most laterally. And so this is why in survivors of extreme prematurity who have suffered this periventricular injury and periventricular leukomalacia, they end up with spastic diplegia, because the fibers that are closest to this region are those which are going to supply the lower limbs. All right, is that clear? Can I move on?
Yes, Doc, thank you.
Okay, remember I'm not seeing you, so please check in from time to time. All right, so in terms of the diagnosis, as usual, we go through the history, the examination, and we may need to do some investigations. So as you can see, the history is important, the onset. All right, when did it occur, this weakness? Was it something noted from birth, 6 months, later in childhood, adolescence? What was it? Was it something that occurred acutely? And what was the course? Was it acute, subacute, chronic? What is the perinatal history and the antenatal history? Because you want to know if there are any teratogenic exposures, any genetic disorders, any perinatal insults. What's the rest of the developmental history? Is this just confined to the motor system, or is it affecting language, social and adaptive milestones, etc.? Growth and nutrition are important, because it may tell us that particularly if you have a child who has disordered growth, this might be genetic. Or if you have a child who has significant spasticity, problems swallowing and so on, that might compromise nutrition and growth. We want to know if there's any injury, any toxin exposure, any acute illnesses associated, any drugs associated. We want to know the family history, whether or not there's a family history of a similar problem. Remember, like Duchenne muscular dystrophy is an X-linked recessive disorder. And so we'd often ask about a family history of male affected relatives on the mother's side of the family. The social history, because children are prone to neglect and abuse when the social fabric is not strong, but also if you have a child who has a disability, then this stresses the social structure of the family. And then you want to do a systematic inquiry to see whether or not there is involvement of other organ systems. Remember, you could have a child who could have, we spoke about sickle cell disease causing stroke. You could have a cyanotic heart disease causing stroke, etc. So the full history is important. The examination, in terms of the general examination, we look for things like growth to anthropometry, neurocutaneous, stigmata of neurocutaneous disease, so features that might tell us that this is likely neurofibromatosis type 1 or tuberous sclerosis or hypomelanosis of Ito. dysmorphisms, because that may tell us that there's a genetic basis for this. And the presence of cardiomegaly or hepatomegaly should make you think about a storage disorder like a glycogen storage disease. And then the presence of arthrogryposis, which means contractures that the child was born with, limb contractures, should make you think about something like a congenital myopathy. We did the full neurological examination, standing, sitting, and recumbent. So the neurological examination is, as we always know, so we do higher function, examine the head, neck, and spine, examine the cranial nerves, the motor system, the sensory system, reflexes, and for autonomic dysfunction. Is that a question?
Yes, Doc. Could you go back to the last slide for 1 second, please? So when you're conducting the exam, right, usually in this exam you give the patient a lot of instructions. You know, you would say, you know, like you tell them what to do when you're trying to pick up certain things. So my question is, in a child, well, an infant who obviously is not able to communicate like us, how do you elicit certain things? For example, if you want to assess flexion at the knee or something of the sort.
Right, and that's a very good question. So in young children and children who are unable to follow instructions, then one or powers of observation are very important. So you want to inspect to see what the child thinks, like, you know, is there wasting? What's the posture that the child adopts? And what spontaneous movements, active movements the child has. Then because they can't follow instructions well, then you use play. Okay, so you could take a child's toy and probably see if they could reach for it. If they can reach for the toy and hold on to it, then you offer some resistance and you see if they can pull it away from you with some resistance. So we use both inspection, the child's usual function and movements in their environment, as well as play, to examine the nervous system, the motor system in children. You will have some examples at the end of this lecture where you will be asked to assess the neurologic exam without touching the child, because you'll just have images and come to an assessment. And so hopefully that will be illustrative for you.
All right, thank you, Doc.
Good. All right, so in terms of the motor system, we look at bulk, tone, power, coordination, the presence of any involuntary movements, the child's station, mean what they look like standing, and also their gait. And as we said, observation is very important, looking at posture, how they manipulate objects, the muscle bulk, spontaneous movements, and the child's gait. And as you have brought up, there are difficulties with the examination if they can't cooperate, if there's pain, or there's profound hypotonia. Some investigations that are important include the ultrasound, which is useful in infants, a CT scan, which gives the best resolution of bone and blood, and the MRI, which actually gives the best resolution of parenchymal structure. But the CT has a drawback in terms of radiation exposure, which can be excessive for a small infant. And the MRI has a drawback in that it requires sedation, because the child has to be perfectly still and for 30 to 45 minutes. So the ultrasound actually is a good tool to use because it requires no sedation. There's no radiation exposure. It's relatively inexpensive and accessible in infants. So just some examples of something we could see here. So this is an ultrasound, cranial ultrasound of a child, and this is showing you can see that these are the ventricles, the frontal horns and the temporal horns, which are enlarged. And this is a side view of the lateral ventricle, and you can see it's enlarged. So what would you say is wrong with this child? This is the third ventricle, which is also enlarged. What would you say is wrong with this child? Anybody?
They have hydrocephalus.
Right. And this was actually a preterm with some post-hemorrhagic hydrocephalus. This is a CT scan of somebody with cerebral palsy. And you can see here that the cortex looks okay, but there is this is the corpus callosum, and you can see that in the body of the corpus callosum, it is quite thin, and that speaks to significant white matter injury. And then this is an MRI brain, again showing significant white matter injury with a thin corpus callosum and expanded ventricles because the white matter is quite thin and atrophied. Other investigations that may be important include muscle enzymes if you think the child has muscle disease, serology for torches or dystrophin or acetylcholine receptor antibodies or genetic studies, electrolytes, and special studies, which would include CSF if you think the child has meningoencephalitis or Guillain-Barré syndrome. If you think the child has a neuropathy, you want to order a nerve conduction study. If you think the problem is at the level of the muscle, you want to order an EMG. If you think there's myasthenia gravis, you'd want to do a tensilon test as well as order acetylcholine receptor antibodies. And a muscle biopsy may be useful if the child has muscle disease or spinal muscular atrophy. So just going back to this, does anybody know the CSF findings that are seen in Guillain-Barré syndrome? Okay, I can go back. No? So remember with Guillain-Barré syndrome, we said it was, there was demyelination post some exposure, some post-infectious exposure. And what we tend to see is a characteristic finding on the CSF where there's an elevated protein without a concomitant elevation in the white cells, and that condition is called cytoalbuminous dissociation. Now, anybody knows about the tensilon test? Because you haven't asked me about that. Do you know about the tensilon test? No, yes. Move on to the next slide, you know it, or do we need to go through that?
Can you just remind us, Doc? I heard about it before. Yeah,
okay.
Please remind us.
Remember, you need to talk to me, and I'm not seeing you, okay? So tensilon is a trade name for a drug called idrophonium. And idrophonium is an acetylcholine esterase inhibitor, which is short-acting. With myasthenia gravis, the child, it's an autoimmune disease where the child produces antibodies to their acetylcholine receptor on the muscle end plate. So what happens is that you have fewer receptors for acetylcholine to bind to when acetylcholine is released from the vesicles at the nerve terminals. When acetylcholine is released and binds to the acetylcholine receptor, the natural process is that acetylcholine esterase will, after a short time, mop up the acetylcholine, cleave it, and the muscle contraction will end. You will have muscle relaxation. When you give acetylcholine or tensilon, because it's an acetylcholinesterase inhibitor, it inhibits the acetylcholinesterase and allows the acetylcholine to stay in the neuromuscular junction for a longer time to saturate more acetylcholine receptors. And so that results in a temporary improvement in strength of the muscle that is being observed. So the tensilon test is useful as a bedside test in myasthenia gravis, particularly when there's ocular involvement with ptosis. And so if you have a positive tensilon test, when tensilon is given, there is temporary improvement in elevation of the eyelid and reduction in ptosis. And so that's a positive tensilon test. Is that clear?
Yes, Doc.
Okay, thank you. All right, so I
Excuse me,
said we're
Doc,
going.
before you move on, can you repeat the name that you give to the condition where you have elevated proteins in
Right,
the environment?
cyto, 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 albuminous, so ALBUMINOUS, dissociation. And it means that you have an elevation of protein without an associated elevation in the white cell count. Okay?
Okay, and you said that the tensilon test is useful for patients with, you said something relating to the eye. What was that term?
Myasthenia gravis with ocular involvement, and so there's usually ptosis.
Okay, thank you.
I'm going to try and show you that video of the GMFCS before we wrap up this lecture. Let's see if this works. Sorry, wrong one. No, right one. So tell me if you're hearing. Are you hearing?
No, Dr. Singh.
Okay, well. Okay, well, we'll leave that alone. I don't know how to fix that right now. But I'll share that video with you and you promise me you'll go through it. Because when you come to clinic, you're going to be able to use the GMFCS to assess your patients. Okay, so for that student who asked me the very good question, how do we examine these patients when they can't cooperate with us? Here we go. So I want you to describe for me what you're seeing in each of these slides representing cases, and then I want you to tell me where you think the lesion is and what you think the diagnosis is. All right, so here's the first case. Please describe for me what you're seeing.
Can I try?
Yes, please do.
Okay, so this is a what appears to be a female infant who is standing on a chair, well, on her mother's lap. Specific to the lower limb, the foot is, both feet are externally rotated. Her hands are in a fisting position, slightly flexed at the elbow. Stick to the face.
So the hands are fisted. Anything in particular about the way the hands are fisted you want to highlight?
Well, the thumb would have been flexed and then the other 4 digits flexed around the thumb.
Right, and that pattern of fisting is called cortical fisting. Okay, very good. Anything else you want to say about the child? So the lower limbs are externally rotated. What age group you think this child is?
She appears to be about, well, the fact that she can't stand, she's over a year, so probably 3, 4.
Okay. Do you think a child just learning to walk like this would stand with the lower limbs so close? How did
They usually have like a broad base.
a broader base? So what might that be telling you?
So this child would have issues with walking because the way that she sets her feet, it would be almost impossible, or she would have to like have to increase the space between the legs, so she'd go in a like a circular way to move.
Well, no, what I was trying to point out is I think that this means that she has her lower limbs are excessively adducted. Okay.
Okay.
All right. Okay. Anything about her facial expression?
Well, her eyes, those appear to have a bit of, what's that, strabismus of the right eye. It's, yeah. And then now that's not a typical smile, but I don't know if it's just the way that the picture was taken, like he shows mid-sentence.
Okay. It's just a bit of, that's probably a bit of grimacing. So you have said a lot. What do you think about her muscle bulk?
She does appear to be, her body habitus is reduced, but
Right.
it's not
So
grossly.
this good. So Anya, you've done so very well. What do you think? Where do you think the lesion is here? Do you think it's upper motor neuron or lower motor neuron?
Well, I'd need to take an adequate history and do an examination
No, just
to
from
see if there are
this.
any
What do you
signs
think?
of,
No,
okay.
no, 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 no.
So the
Just
fact that
from this.
the bulk, so if you're thinking about the bulk being reduced, that's more common in a lower motor neuron lesion,
But
but it's
remember,
also seen in a chronic upper motor neuron lesion as well.
absolutely. Remember, I told you that that pattern of fisting is in keeping with upper motor neuron
Upper
disease.
motor.
And the way she holds, do you think that is the posture you'd have of the lower limbs if this was a lower motor neuron lesion?
Lower motor. It would be turned inwards. So,
Well, not really, but
or
the way it is with the excessive adduction is the posture that you tend to get with spasticity. Okay, so this is an upper motor neuron lesion, and what do you think the diagnosis may be here?
so this child, it could be congenital or acquired.
No, just a diagnosis. Give me a diagnosis, one term. Anybody else can help Anya, who has done so well?
Could it be spinal muscular atrophy though?
No, remember we said everything here is pointing to upper motor neuron involvement. The posture, the cortical fisting, and this is something of long standing. So what upper motor neuron?
Could it be the periventricular leukomalacia?
It could be, but just a cerebral palsy. Okay?
Okay, doc.
All right. Okay, let's move on to the next one. Tell me what you're seeing there. Anybody? Okay, so Anya again, you want to go?
Okay, I'll try again. So, this appears to be a male, who's seated on an examination table. He has normal, well, adequate bulk, to the arms, to the forearm. No, the arms. Specific to the forearm hands. The forearms do appear to be of decreased bulk, and the right hand, um, the what do you call that? The fifth digit is flexed. Fifth and second digit are flexed. Specific to the lower limb now, both lower limbs are markedly decreased in bulk. In all muscle groups. The foot is in dorsiflexion,
No, but you're saying it right the first time.
plantar
Plantar.
flexion,
Mm-hmm.
and then the hand, the same hand, yeah, the index and the index, the middle, and the fifth digit are flexed.
Okay,
And I
that's a
think
very good,
he's trying to be in the neutral position.
very good start. What this is pointing out, which it might not be clear to you, is that there is wasting of the thenar and hypothenar eminences. Okay.
Okay.
Anything else you want to say about the feet apart from being plantar flexed at the ankles?
The what do you call that? Cavus. It's the
Yes.
arch of the foot.
Is increased, right? So,
Yes.
Anya, very good. I'm going to ask somebody else to tell me, where do you think this lesion is? Is it upper motor neuron? Is it lower motor neuron? Or is this a normal exam?
Doc, I think this is a lower motor neuron lesion.
Very good. Akil, why did you say that?
Well, the notable difference in wasting from the lower and upper limb, especially as it relates to the arm. And then I also remember that you were saying earlier, I think it's Guillain-Barré, that's a progressive condition from distal to proximal, and I think that seems to be what's happening from the lower limbs going up.
Okay, with Guillain-Barré, Guillain-Barré is an acute illness, and you don't tend to get this pattern, this degree of wasting. So I'm in agreement with the Akil that this is likely to be lower motor neuron because the findings are more distal, right? And you have distal wasting in the upper limbs. But if you look at this young man, it was a young man, do you think this started a day ago, a week ago, a month ago, many months ago, years ago? What would you hazard a guess?
Probably more like years, Doc.
Right, so it's something more chronic, right? So can
Yes, Doc.
you just suggest and so if it says lower motor neuron, do we think it's at the level of the anterior horn cell, or do we think it's a neuropathy, or do we think it's a myopathy?
Uh, Not sure that, but I think I'll go with I think it could be a myopathy.
Okay, probably not a myopathy, because remember we said myopathies tend to cause more proximal involvement, right? So this is definitely distal with this pes cavus deformity. So this is likely to be a neuropathy, right? Anybody suggest a condition that could look like this? You've done very well so far, everyone. No? Okay, we'll see at the end. All right, this is Anya. Go ahead.
Dr. Chambers, for the previous picture, seeing that we are saying that we said that it was a low motor neuron problem.
Mm-hmm.
That's what we're thinking. Could it be
Yes.
the level of the spinal cord?
Okay. It could be. It could be spinal cord. We would have had to, when it's a spinal cord, not like a myelopathy, because that would give you only lower limb involvement, right? So it's either a neuropathy or anterior horn cell. Okay. This child actually had a hereditary motor sensory neuropathy. All right, moving on. So let's do this case. Anyone know? Let's go and somebody else who has not spoken before. So we've heard from Akil and we've heard from Anio. What do you think what are we seeing here, and what do you think the diagnosis is?
All right, doc. Let me give it a try. All
Yeah,
right.
man.
So,
That's right.
so on the left, well, there's a picture or image of a young male. On the left, there appears to be increased bulk of the calf muscles. On the right, there's some abnormality with respect to the spine.
What abnormality is that?
What do I call this now?
Just describe what you're seeing, and then we could put a name to it.
Would it be like I don't know if I'm going to call it like is it like an excessive kyphosis or something like that? I don't know.
Lordosis.
Lordosis, my bad. Yeah, lordosis.
Lordosis. Right. Good. What else? What do you think about the scapulae?
Probably winged, I would say.
Right. What do you think about the muscle bulk in his upper limbs?
Oh yeah, the muscle bulk is definitely decreased in the upper limb.
Where in the upper limbs is it decreased?
Oh, in the arms and shoulder.
Right, but it's the shoulder, right? So that's proximal wasting, right? So if you put all of that together, what are you thinking?
So it's there's wasting.
What diagnosis are you considering?
In this case, would it be there's wasting lower motor, like a muscular dystrophy?
Lower motor, okay. And at what level?
At the level of the muscle.
All right. So what diagnosis are you considering?
This wouldn't be a muscle dystrophy, muscular.
Pardon me?
This wouldn't be a muscular dystrophy. I'm not sure.
Yes, it would be a muscular dystrophy.
Okay.
All right.
Okay.
So this is what Duchenne muscular dystrophy looks like. Very good. Why are the calf muscles enlarged in Duchenne muscular dystrophy?
Not sure about that part, though, to be honest.
Anybody? Get one of you, call a friend.
I don't know. Annie, you want to help me out here?
Poor Anil.
I don't know that.
Anybody?
I was thinking that you'd have, since you have the decreased, probably decreased tone and bulk in the upper limb, I guess the lower limb would compensate.
No, okay.
Have
All right, you
hypertrophy
guys
of the
have
lower
to
limb.
promise me you're going to read about Duchenne muscular dystrophy. All right, add that to your reading list for today. But this is called pseudo-hypertrophy of the calf muscles. It actually looks hypertrophied, but it's not due to increased size of muscle fibers. What happens with muscular dystrophy is that you have early destruction to muscle fibers because of the genetic abnormality in the gene that codes for dystrophin, and dystrophin maintains the integrity of muscle fibers. So you get progressive destruction of muscle fibers, and we see that when we do a blood test in children with muscular dystrophy, because the CPK and AST, which are muscle enzymes, are markedly elevated. So these kids will come in with a CPK of 20,000. If you were to do a muscle biopsy, what you would see here is that you see few fibers and increased fat. So the muscle fibers that are damaged are replaced by fat, and it gives you this appearance of, hypertrophied calves, but it's not a true hypertrophy, it's a pseudo hypertrophy. Clear? And please promise me you're going to read about the Shane later.
Yes,
All right, how about this one? Who's going to take the bite here? Who's going to do this one?
Hi, Doc. I'll try this one.
Go, Sabrina.
Okay. In the first picture, we see a female infant. She has what looks like an enlarged abdomen. She also has her legs, the attitude of her lower limbs. They are in a frog leg position. Her hands, they're not okay. Her hands aren't in any fisting, but her feet are in more of a kivas position, more like curved inwards. And right, that's the first picture. In the second picture on the right, you can see clearly she has like decreased muscle bulk in her upper limb. And increased skin folds around her armpits. And okay, and then the last picture, I think they're showing her, I'm not sure, her inability to keep her head up, or is it her spine is curved, has more of a kyphosis. I'm not sure though.
Okay, 1 second for me. Hospital. Hello? Okay, I gave it to Dr. Griffiths because she thought it was Dr. Dyers. So Dr. Shadale Griffiths has the case. Yeah, probably Dr. Griffiths should be there, or she could be called to find out. Well, give it to the student. Mhm. All right, so that was, who took that? Sabrina?
Yes, Doc.
All right, so I'm going to help you out with this one. So it's important to recognize that the child has an NG tube inside too, and also has oxygen at the bedside. So that tells us probably there's an issue with swallowing and probably the need for some oxygen support, right? So now the child, I agree with you, has a frog-legged posture. But when you look at the child is in the first picture looking at something, so seems to be alert. But do you agree with me that there's a lot of wasting of the muscles of the upper limbs around the chest and the lower limbs?
Yes, Doc, I do.
All right. And if you look at the chest shape, I know you thought it was the abdomen that was enlarged, but what is actually happening is that you have a sort of triangular shaped chest with a pectus carinatum or a prominent sternum. All right. So
Okay, Doc,
that
I'm seeing.
triangular or bell-shaped chest is due to muscle wasting around the chest. All right. The pectorals are wasted and so on. This second picture shows that she has marked head lag. This is a child who probably looks like at least a year old, and head lag should have resolved by age 6 weeks, right? So if you have marked head lag, what is that saying to us?
That she has maybe her neck muscles aren't able to pull her head up.
Right. So she has truncal weakness. Okay. Now, when she is suspended ventrally or horizontally, she's not able to bring her head into the horizontal plane, and her lower limbs just sort of dangle. So again, this is in keeping with truncal weakness because she should be able to lift her head above the horizontal plane and flex those lower limbs under her trunk. All right. So having seen this, where do we think the lesion is?
I think this would be an upper motor neuron lesion.
Okay, but remember, what does the frog leg posture tell us?
Oh, sorry, no, sorry, I changed my answer. Lower motor neuron lesion.
Lower motor neuron, right?
Yes, and the frog
And
leg means that there's a lot of hypotonia.
Tonia, right. So she's very hypotonic. She looks weak. She needs oxygen. She needs some support to be fed and so on. Where do you think in the lower motor neuron lesion this is? Is it at the anterior horn cell, the peripheral nerve, or at the muscle?
I'm not sure, Doc. I'm
Yeah,
thinking
take a
because
guess.
because it seems to be most of her body that's included. I would go more with maybe an anterior horn cell.
Okay, you did the right guess. Okay, so she also had fasciculations, and she actually is a child who started off with a normal history, normal perinatal history, normal milestones up until about 4 to 6 months, then got progressively weak, and then this is how we met her at a year with marked weakness. She was floppy, hyporeflexic and she had fasciculations. What diagnosis would that be? She had spinal muscular atrophy, okay, which in Jamaica is a lethal disease. All right, let's look at this case and tell me what you see. Anybody who have not heard from before? So I don't want to call a name. Does somebody else want to try this one? I will point out to you that the child is holding a bottle in the left hand. Okay, Sabrina, go ahead.
Yeah, I was about to say I don't mind trying again, but okay. So this child seems to be a male infant. He is sitting up unassisted, and he is in his left hand seems to be holding a bottle, quite fine, and however his right hand seems to have it seems to be flexed at the elbow and also at the wrist, and his hand is in a fisted position. I can't see the position of the thumb, but I think it's within the fingers, which represents cortical fisting. And then for his lower limbs, his left leg is flexed at the knee, around the bottle. I don't know if that's intentional or if it's fixed like that. But then his right leg, it seems to be straightened, not fully, but it's not fixed in that curled position like his left leg.
You think his left upper limb is quite functional?
I
holding the bottle.
I want to think yes, thinking that he wants to
I
hold the
agree with
bottle.
you. What
Okay.
about the right upper limb?
I think the right upper limb, it seems too unnatural for that to be. So I think there's a
Right.
pathology. That's right.
So what do you think is wrong with this child?
I think he has, because I can't assess his legs properly, I want to say it's either a monoparesis or it could be a hemiparesis.
Full marks. Very good. All right, last case. Who wants to do this one? Tanya Anderson?
Okay, let me see.
Go ahead.
Okay, I'm seeing a photo of what seems to be a young female. Looking at her face, I'm seeing that there's significant logging of the eyelids bilaterally. What's that? Is that ptosis? Not sure.
Yes, that's called ptosis. Yes, very good.
And what else am I seeing? Is that excessive sweating on her face? I'm not sure. Her face seems.
No, probably just the lighting. Is there a diagnosis that jumps out at you?
Yes, myasthenia gravis with ocular
Very good.
manifestation.
Very good. So apart from the ptosis, you notice she looks sad, and this
Yes,
is because she has an expressionless faces. So there's actual weakness of her facial muscles as well. Okay, but this is myasthenia. All right, so the first case that we looked at, that child had cerebral palsy. We picked up the strabismus. The dyskinesia was suggested by the grimace of the mouth. and it's spastic cerebral palsy, but the lower limbs are more involved than the upper limbs, are spastic diplegia. The second case was a hereditary motor sensory neuropathy. This was Duchenne muscular dystrophy. This was spinal muscular atrophy. This was right hemiparesis. And the last case was myasthenia gravis. So you can see that without even handling the child, we can get a lot of information that guides us towards a diagnosis. All right, so in summary, we would ask ourselves, where is the lesion and what is the lesion? Remember that age influences the presentation and pathology. As I think Annie was saying, history is most important, but for the examination, observation is key. All right, so I think these are on BBC, and you can get the link from for the video from there, okay? We have one more lecture to do. Tell me if you need a 90-second break.
Yes, Doc. Please.
All right. Okay, go ahead. Okay, you got your water break and ready to go?
Yes,
We're
Doc,
going to
I'm back.
begin, all right? Mm-hmm. Okay, so we're going to go through the headache in children. This is, I think, a less intense lecture, so let's go right ahead. So we're going to go through this presentation, discussion on the prevalence of headache, the mechanisms, the types of headache, the diagnostic approach, and the management of headaches in children. So headaches are quite common. 3 to 8% of 3-year-olds would have had a headache in life, and up to 80% of adolescents would have had headaches at some point in life. Migraine has a prevalence of 7.7%, and it's more common in males pre-pubertally and in females post-pubertally, whereas tension-type headaches are very common and affect probably 1 in 4 individuals. In terms of headache patterns, there's occasional headache, so that's probably what we'll see in a lot of young children, a headache with fever or with minor head trauma. Then we have the recurrent headaches, which occur over time and are usually suggestive of a primary headache disorder, including migraine and tension-type headache. We'll speak a bit more about that later. Then we have the persistent or worsening headache, which is this headache is getting worse each day, more severe, more frequent, with probably associated symptoms. And once you get that pattern, you need to think about raised intracranial pressure or brain tumor or some other space occupying lesion. And then we have the chronic daily headache, which is a headache occurring on 15 or more days for the month, and that usually is following a primary headache disorder complicated by analgesic overuse or by depression. So what's important for us to understand is that the brain itself has no pain receptors, so the brain is insensate to pain. When you rotate through surgery, you will notice that, the neurosurgeons can do their brain surgery to the patient awake. The pain receptors within the cranial space are located on the meningeal arteries, the proximal portions of the cerebral arteries, the dura at the base of the brain, the venous sinuses, and with cranial nerves 5, 7, 9, and 10, and the upper cervical nerves. So when we have headache due to intracranial pathology, it's associated with significant inflammation or stretch of the dura. Also, because we have intracranial pain receptors, but from extracranial structures, then we have extracranial conditions that can cause headaches. So we may have headaches related to muscle strain or eye strain, sinus congestion, carious teeth, temporomandibular or cervical joint dysfunction, muscular stress and injury. All of those can cause headache. And similarly, we can apply the mnemonic tin can bed me D to come up with some potential causes of headache. And I will leave you to review this in your own time. Now, the 2 main primary headache disorders are migraine and tension type headache. Migraine is further classified into migraine with aura and migraine without aura. The diagnostic criteria for migraine with aura, you must have more than 2 attacks. For migraine without aura, more than 5 attacks. The headaches are of long duration, 4 to 72 hours in adults, and we say at least 1 hour in children. The headaches are of a moderate to severe intensity, so usually you cannot continue your activities as usual with a migraine headache. They're often located temporally or frontally with a pulsating or throbbing characteristic and accompanied by nausea, vomiting, photophobia, or phonophobia. So for the International Headache Society, to diagnose migraine without aura, you need at least 5 attacks, fulfilling criteria B to D. And B includes the duration. So in children, it's 1 to 72 hours. The headache should be moderate or severe in pain intensity. Unilateral in location, but in children is often bilateral, of a pulsating quality, and aggravated by or causing avoidance of routine physical activities such as walking or climbing stairs. And during the headache, you should have at least one of the following: nausea and or vomiting, photophobia and phonophobia. And importantly, it should not be better accounted for by another diagnosis. For migraine with aura is similar to that previously, but you should have one or more of the following fully reversible aura symptoms, most commonly visual, but also including sensory, speech and or language, motor symptoms, brainstem symptoms, or retinal symptoms. The auras usually spread gradually over 5 minutes, and the aura symptoms should not last longer than 60 minutes. And the aura usually is accompanied by a headache within 60 minutes. It's important to recognize that this should not be better accounted for by another diagnosis, and that a transient ischemic attack should have been excluded to make the diagnosis of migraine with aura. So as we said, the commonest auras are visual, but you may have dizziness, abdominal pain, paresthesia, transient hemiparesis, and transient aphasia. These are just some representations of common visual auras, including fortification spectral, scintillating scotomas, shimmering scotomas, visual field loss. And there are other ones which include black dots, kaleidoscopic patterns of various dots, of various colors, or distortion of size, appearing smaller than reality or larger than reality, so micropsia or macropsia, and also images appearing inverted, metamorphopsia, the so-called Alice in Wonderland syndrome. Just want to point out a particular migraine type, migraine with brainstem aura, because we see that in a number for adolescents, where the aura may include dysarthria, tinnitus or ringing in the ears, diplopia, double vision, vertigo, dizziness, hypoacusis, sounds seeming more distant than they really are, ataxia, and decreased level of consciousness. But there are no motor or retinal symptoms. So these children tend to present with headache and dizziness, headache and syncope, and they would have one or two other of these brainstem symptoms. So as we said, in childhood, migraines are of shorter duration. The children sometimes are not able to articulate the description. The headaches may be non-pulsatile. Severe pain is seen in 50%. The headaches are often frontal or bilateral, and there may be no photo or phonophobia. Now, there are some precursors of migraine in children, including abdominal pain. There are other precursors we'll discuss. In childhood, there's a high placebo response to treatment, and there's a higher rate of spontaneous remission. Now, migraine pathophysiology. It is believed that the person who has migraine their cerebral cortex is inherently hyperexcitable, and that the aura of migraine may be due to a phenomenon called cortical spreading depression. The trigeminal vascular system is central to the pathophysiology of migraine, and we'll speak about that. There seems to be some central facilitation of normal sensory stimuli, and there are genetic factors. So as we said, migraineurs are thought to have a hyperexcitable cerebral cortex, and it's thought that there are genetic factors that cause disturbances in neuronal ion channel function, which trigger episodes of regional neuronal excitation followed by cortical depression. This cortical depression starts occipitally and moves anteriorly and is associated with suppression of EEG activity and regional oligemia. The fact that it begins in the occipital region and moves anteriorly is thought to be responsible for the patient's aura, which is most often visual, or the patient's focal neurologic symptoms, or both. So what would happen is that you have regional excitation, which is here, and it moves anteriorly, it's followed by neuronal depression. And so we can see on the EEG that there is excitation followed by depression. And this cortical spreading depression moves anteriorly until it gets to the central sulcus. When it gets to the central sulcus, it spreads ventrally to the meningeal trigeminal fibers, and this is when the headache begins. It's believed that the trigeminal sensory nerves, when activated, trigger the release of some vasoactive peptides, including calcitonin gene receptor peptide, neurokinin A, and substance B. And these vasoactive neuropeptides trigger vasodilation, dural plasma extravasation, leading to inflammation. And then pain impulses are transmitted along the trigeminal vascular system to the trigeminal nucleus caudalis, then to higher cortical centers of the brain. So I think it's just important to know that migraineurs have an inherently hyperexcitable cortex due to genetic alterations in their neuronal ion channel function, that the migraine episode starts with neuronal excitation followed by depression. This starts occipitally and moves anteriorly. Once it gets central sulcus, it moves ventrally, and once the meningeal trigeminal nerve fibers are triggered, they release these neuropeptides, which lead to inflammation and the pain. Serotonin is also released from platelets at the beginning of a migraine attack. There are 3 types of serotonin receptors: 5-HT1, 5-HT2, and 5-HT3. 5-HT1 receptors are inhibitory, while 5-HT2 are excitatory. And so the drugs that we use for migraine, including triptans, are actually 5-HT1 agonists, while some of the prophylactic agents we use are 5-HT2 antagonists. So some precursors of migraine include cyclic vomiting, recurrent abdominal pain, paroxysmal dizziness, paroxysmal tilting of the head or torticollis, recurrent limb pain, recurrent chest pain, and infantile colic. Just tell you about cyclic vomiting. So it's a diagnosis that's usually made in retrospect. The child will have episodes of vomiting, which tend to cluster. So they vomit so excessively, they often become dehydrated. There may or may not be mild diarrhea associated, but no cause is found for the vomiting. Then they go through symptom-free intervals, and then they have the recurrent vomiting again, and this pattern continues. Usually over time, the child goes on to develop migraine, and so it's in retrospect that we look back and we say, oh, these vomiting episodes were likely due to cyclic vomiting of childhood. Now, migraine triggers include emotional stress, hunger, dehydration, lack of sleep, exposure to loud noise, bright lights, strong odors, airborne pollution, when it's extremely hot or cold, excessive exercise, minor head trauma, menstruation, food ingredients, and analgesic overuse. The food triggers of migraine are not common. They only occur in about 25% of persons who have migraine, but include things like alcohol, beer and red wine with the sulfates, aged cheeses, chocolate, citrus, artificial sweeteners, overuse of caffeine, monosodium glutamate, salty foods, and processed foods. Migraine is not an atopic disorder, but it is associated with atopic disease quite frequently. So migraineurs often will have a history of asthma, allergic rhinitis, or atopic dermatitis. They often have a history of motion sickness, teeth grinding. Epilepsy is not common, but it's an associated disorder as well as sleep disturbance. Any questions before I move on? Okay, tension type headache is another primary headache disorder. And in this headache disorder, you need at least 10 episodes. The headaches may be of shorter duration, 30 minutes, but lasting up to 4 days. The headaches are often bilateral. They're not pulsatile. They're mild to moderate, so you may be able to go along with your activities even though you're having these headaches. And there's the absence of nausea, vomiting, phonophobia, and photophobia. The tension type headache pathophysiology is not well understood, but just to say that muscular and psychogenic factors are believed to be associated with tension type headache, and I won't go into the details otherwise. Chronic daily headache, which speaks to headaches occurring on 15 or more days for the month, are usually seen with chronic migraine or chronic tension type headache or new daily persistent headache. The risk factors include medication overuse, snoring or obstructive sleep apnea, obesity, excessive caffeine consumption, and psychiatric comorbidity, especially depression and anxiety. So medication overuse headache refers to overuse of analgesic drugs for 3 or more months, and it occurs when you have medication use on more than 15 days of the month. So what happens is that you have frequent headache, you take your frequent simple analgesics, your NSAIDs or your acetaminophen. When you get analgesic withdrawal, there is more headache, a rebound headache, which leads you to take more analgesic medication. You get analgesic withdrawal again, more medication, more headache, and you end up with a vicious cycle. So the diagnosis of headache requires a history. We want to know about the location of the headache, its intensity, the onset, its course, the duration, the frequency, and any accompanying features, the nausea, the vomiting, photophobia, phonophobia, osmophobia with smells, any preceding or following events, and things that make the headaches worse or relieve the headaches. The past medical history is important, as is a family history. Migraineurs tend to have 80% of children with migraine have one or more parents who have migraine. The social history is important because where there's a lot of social dysfunction or stress, that may trigger or be a contributing factor to the headaches. The academic progress is important because we tend to see headaches in two main student types: the overachiever who is excessively driven, and also the student who is struggling. Emotional features are important, and so we must inquire about this, especially in adolescents and older. Do a good head history, because we know that especially with chronic daily headaches, depression and anxiety are predisposing factors. The medications that are being used, because headaches could be side effects of medications, and also because we're aware of the phenomenon of analgesia overuse rebound headaches, and also to get an understanding of the impact of the disorder on the child's functioning. Because certainly if it's affecting the child's functioning, we ought to consider some headache prophylaxis. The key examination findings in a child with headache are to rule out secondary causes of the headache. So the head circumference is important because we want to rule out something like hydrocephalus. The vital signs are important because we want to rule out raised intracranial pressure, in which you may have hypotension and bradycardia, as well as headaches may be the only presentation of hypertension. Fundoscopy is important to visualize the fundi to rule out papilledema, which would indicate raised intracranial pressure. The visual fields are important to rule out bitemporal hemianopsia, which would indicate the likely presence of a pituitary mass lesion. Examining for meningism to rule out meningitis or a subarachnoid hemorrhage. Examine for focal neurologic deficits, which would indicate the likelihood of a space-occupying lesion or an infarct, and cerebellar signs and gait to rule out the presence of a posterior fossa tumor. In assessing the severity of pain, the FACES pain rating scale is very important. So the child is telling you she has headache, she grades it at a 8 out of 10, yet her facial expression is 1 out of 5, then that should, make us a bit concerned as to whether or not, she's elaborating more about her headache than it's, really affecting her. Children's drawings have been useful to understand their headaches. So these are drawings done by children in our clinic while waiting to be seen. And so I usually pause here to ask you what you think of these drawings. What do you think about this first drawing on the left? Do you think this is a mild, moderate, or severe headache?
It seems like a severe head.
Yes, I would say that. And you could see the facial expression, right? So these are what the children draw. And this is matching like a 4 out of 5. All right. How about this one in the middle? What would you say? You think it's mild, moderate, severe?
I'd say moderate.
Yeah, I don't think the facial expression moves it to severe, not quite understanding what's radiating from her head. How about this one? What does this drawing say to you?
Which one, Doc?
This third one at the top. So the one to the right, top right.
Severe.
Says severe to you. Okay, anything to anybody else? Does it strike in? Well, go ahead.
I was also thinking severe, not just the arrow and the clouds, but I think he also wrote food that he can't eat, which means like he hurts so much that he can't eat.
Okay. To me, when I see this, I think the child has some depression too. When I see the clouds with the rain and just a bland facial expression, I wonder if there, to me, this just seems that there's some depression there. How about this one in the lower left corner? Do you
Maybe
think this
mild
is
to
mild,
moderate.
moderate, or severe?
I think mild to moderate. I'm not sure.
Okay, I'd say mild. I mean, this looks mild, and this one looks quite severe to me. All right, so the investigations that are done are determined by the history and examination findings. If you think that there is raised intracranial pressure at all, do not do a spinal tap, and the brain imaging would be indicated by what you think the underlying cause is. So the indications for brain imaging in the child with headache would include a child with acute head trauma with concussion. That headache pattern that we say is progressive or a new daily persistent headache, because we want to rule out a space-occupying lesion. If there are any focal neurologic findings or any findings of raised intracranial pressure, for sure. If you have a headache occurring with seizures, you'd want a brain image, make sure there's no lesion associated. In the very young child with the absence of a family history of migraine who's having severe headaches, we should image. And if there's anything that suggests any hormonal dysfunction, so growth arrest, delayed or precocious puberty, or secondary amenorrhea, we should image to see whether or not there's a pituitary lesion. So the management of the headache, we treat the headache, the underlying cause. So if there's an intracranial tumor, they refer to the surgeon. Symptomatic relief, we use simple analgesia, so acetaminophen or an NSAID like ibuprofen or diclofenac. For acute migraines, we can use triptans in children 6 to 17 years old, but the triptans are relatively contraindicated in children with migraine with brainstem aura or hemiplegic migraine, just for fear that it could cause a stroke. And with migraine headaches with vomiting, we often have to prescribe antiemetics as well. In migraine, the management includes education of the parent and patient about what migraine is, that it's a genetic disorder, what triggers, what are the potential triggers, what lifestyle modifications are required, and keeping a headache diary. And that usually results in, reduction in headache frequency within 6 months of the consultation. So for the child with migraine, it's important that they drink sufficient water, they get adequate sleep. Adequate sleep for a 10-year-old to 12-year-old is 10 hours per day. That they eat balanced meals, that they reduce stress, exercise regularly, reduce excessive activity, avoid caffeine overuse, and avoid over-medication. The indications for prophylaxis with migraine would include a frequent headache, 2 or more per week, or the headache that interferes with school attendance or with daily life activities. And the medications that we use for prophylaxis include beta blockers or antidepressants or antiepileptics such as topiramate or valproic acid, antihistamines including cyproheptadine, calcium channel blockers, we don't have in Jamaica this one, flunarizine. We use nutraceuticals, riboflavin and magnesium have been found to be good at headache prevention, and there is a role of botulinum toxin. So in terms of drugs that have been found to be efficacious for migraine prophylaxis, they include flunarizine, topiramate at 1 to 2 milligram per kilo per day, but this tends to cause weight loss and some cognitive clouding. The weight loss may be a beneficial side effect in somebody who's overweight or obese. And then valproic acid, but this can cause drowsiness, dizziness, increased appetite, and weight gain. So you may not want to give this in somebody who's overweight or obese. And valproic acid is relatively contrary indicated in women of childbearing age because of its teratogenic effects. Amitriptyline, cyproheptadine, and a drug we use now for seizures called Keppra have been used, but there's need for further evidence for their efficacy. And propranolol has also been used, but the evidence for its efficacy is not strong. There are non-pharmacological methods to prevent migraine, and for this we would refer to a psychologist. So this includes biofeedback, guided imagery, progressive muscle relaxation, and cognitive behavioral therapy. Acupuncture, acupressure, self-hypnosis, and music therapy can also be used for migraine prophylaxis. For tension-type headache, we want to remove the precipitating stress, do a psychological evaluation, refer for counseling, and we can consider a drug which is an antidepressant such as amitriptyline, and also the use of non-pharmacological measures. So I'm going to pause here and ask if there are any questions.
Hi, Doc. I don't remember if we went through this, but how do we treat the patient who has the analgesia overdose?
Right, so that would be an indication for prophylaxis. So you have to stop the analgesia, and they're taking the analgesics because they're having frequent headaches, more than 2 days per the week. And so this would be an indication to use medication for prophylaxis.
Oh, okay. Thank you.
Any other questions? Okay, so the most important part is the education of the parent and patient and regularizing the activities of daily living. The headache diary is used. You ask them to keep a diary, the date and time they have the headache, how long it lasts, and what were they doing or what did they eat in the day preceding. And this is really to determine whether or not you can pick up any reliable, consistent, associated factors with a headache. All right. Okay, are there any other questions? Because we're going to go into some cases for you to solve. All right, so we're going to give you a couple of cases for diagnosis. And this one is a previously well 2-year-old boy presenting with a 3-day history of fever, headache, and vomiting. 2 other children at the same daycare nursery have recently had febrile illnesses. This little boy is fully immunized. When he's examined with his history of fever, headache, and vomiting, he has a temperature of 39 degrees Celsius and a pulse of 120. So he is pyrexic. And apart from slight resistance of his neck to passiflexion, the examination is normal. What is the likely diagnosis here?
Doc, could this be like meningitis?
Absolutely. Right? So because he has meningeal signs, right? And he has fever, headache, and vomiting. Very good. How about this child? A 10-year-old girl who presents to the clinic with a 1-year history of recurrent severe throbbing frontal headaches. Headaches associated with nausea, vomiting, and dizziness, triggered by hunger, relieved by sleep. and she continues to obtain excellent grades at school and plays on the school soccer team. Mom suffers from similar headaches, and the physical examination is otherwise normal. What do you think the likely diagnosis is?
That sounds like chronic tension headaches.
Okay. Who was that, Sabrina?
Yes, Doc, that was me.
Yeah. Okay. So, but this is a history of recurrent severe throbbing frontal headaches with nausea, vomiting, and dizziness, triggered by hunger, relieved by sleep.
Oh, so Doc, would it be a migraine instead?
Yeah, migraine without aura, right?
Right.
And
I
mom
was
has similar
wondering.
headache.
Right, I was
Yeah,
wondering if because she had the good grades still, that it didn't really affect her per se, like physical activity or school.
yeah, but this is what some of you have migraine and you are these very driven individuals who excel in all aspects of life, right? So yeah, so what makes it migraine is it's recurrent, it's severe, it's pulsating or throbbing, and its location being frontal. The association with nausea and vomiting, and triggered by hunger. Those are all classic symptoms of migraine. How about this case? A 6-year-old boy presents to the clinic with a 4-month history of persistent headache. The headache has been accompanied by vomiting over the past 1 week. When he's examined, he's well nourished, but he has intention tremor of the right arm and an unsteady gait with a tendency to drift towards the right side. The physical examination is otherwise normal. What is his likely diagnosis?
Is it a tumor in his, or a space occupying lesion in his cerebellum?
Perfect, Sabrina. Excellent. Do you know what cerebellar hemisphere is affected in this case? So he has intention tremor of the right arm, and he has an unsteady gait with a tendency to drift towards the right side.
I can't exactly remember, Doc. I'm sorry, I can't remember if it
Okay,
crossed the
just say
over.
that cerebellar signs are ipsilateral. So this is there for a right cerebellar hemisphere lesion.
Okay, got it, Doc. Thank you.
Excellent. All right, how about this one? A 15-year-old girl presents with a 2-year history of recurrent, moderate intensity frontal headache that may last up to 3 days. No associated symptoms. She has average academic performance through high school, and that has been maintained, and she was recently appointed a prefect. Her parents separated a year ago, so she lives with her mom and 8-year-old sister. And apart from a cafe au lait mark on the left arm, the physical examination is normal. What's the likely diagnosis?
Could this be like a tension type?
Very good, Jamaica, very good. All right, a previously well 4-year-old boy presents with a history of severe global headache shortly after arising that morning. While drinking his milk at breakfast, the cup falls from his right hand, and his mother notices that as he walks back to the bedroom, he's dragging his right leg. When he's seen at the emergency room at the hospital 2 hours later, is very drowsy, has severe headache, and is found to have an obvious right hemiparesis. What's the likely diagnosis?
Doc, I think he had a cerebrovascular accident.
Excellent, Akil. What side?
Left side.
Very good. Excellent. So checking your answers, the first one was meningitis, likely aseptic. He was mildly ill, not toxic. The second diagnosis was migraine without aura. The third diagnosis was right cerebellar hemisphere tumor, and tension type headache and ischemic stroke. Excellent. So just remember now that the history is the most important tool in diagnosis. The primary aim of your assessment of the child with headache is to exclude secondary headache, and that psychosocial measures are paramount in management. And here are some references. And I thank you for your excellent participation. Are there any questions? Okay, so have a good day. Remember, you're going to read about Duchenne muscular dystrophy, and you're going to look up that video on the GMFCS classification system. All right? Have a good one.
Thank you too, Doc.
Thanks, Doc.
Bye-bye.
Thank
Doc,
you.
Doc, please remember to end the recording.
Okay, will do.